Welcome to the deep dive. Today we're getting into folic acid deficiency.
That's right.
Now you might think, oh, just another vitamin deficiency, but honestly, stick with us on this one.
Mm-hmm.
Understanding folic acid is, well, it's like finding a key piece for your energy levels, your general health, and it's absolutely critical in certain life stages, like pregnancy.
Absolutely crucial.
We've done the legwork, looked at the biology, the clinical side, the impact, and our mission today is pretty straightforward.
Yeah.
We want to pull out the absolute must-know nuggets about folic acid deficiency, so you walk away feeling properly clued in, knowing what actually matters.
Exactly. Think of this as your high-yield tour. What it is, why it happens, how you spot it, what the management looks like. Basically, your essential revision guide for this B vitamin.
Perfect. Okay, let's dive right in then. In simple terms, what is folic acid deficiency?
Okay, so simply put, it just means your body doesn't have enough folate. That's a really important B vitamin, sometimes called B9.
Right, B9.
And it's essential for some really core jobs. Think building DNA that's like the operating system for every single cell.
Wow.
Making healthy red blood cells, the ones carrying oxygen around, and even keeping your nervous system working correctly. It's fundamental stuff.
Really fundamental. So where do we actually get this folate from? And why might levels drop low enough to cause deficiency?
Good questions. So mostly we get it from our diet. Folate is a B vitamin, and it gets absorbed mainly in the upper part of your small intestine.
Okay.
What's kind of interesting is your body doesn't store huge amounts of it. Your reserves typically only last about, say, 4 months.
4 months, really. Not long.
No, which is why getting it consistently from food is so important. A little memory tip might be just to think colorful plant foods.
Ah, I like that. Like what?
Like broccoli, Brussels sprouts, peas, leafy greens. Also things like brown rice, fortified cereals are a big one, beans, lentils, and even fruits like oranges and bananas.
Okay, colorful plants. Got it.
If you don't eat enough of those, or maybe your body struggles to absorb the folate properly, then deficiency can happen.
And the consequence?
The main one we talk about is megaloblastic anemia. That's where your body ends up making fewer red blood cells, and the ones it does make are too big and, frankly, not very good at their job of carrying oxygen.
Right, less efficient.
Exactly. And this is vital. Folate is absolutely essential for fetal development, especially in preventing serious birth defects called neural tube defects.
Okay, that's huge.
It is. It also plays a part in metabolizing something called homocysteine, high levels of which are linked to heart disease and stroke risk. And there's ongoing research into potential links with cancer, though that's still being explored.
So quite a wide-ranging impact. What are the main roots then? The main reasons someone becomes deficient? What's the etiology?
We can sort of group the causes. Diet, as we said, is a major one. Either just not eating enough folate-rich foods or having conditions that cause malabsorption where your gut can't take it in properly.
Like celiac disease.
Exactly. Celiac disease, Crohn's disease, things like that. Heavy alcohol use is another big factor. It really messes with folate absorption and how the body uses it.
Okay.
Even relying heavily on goat's milk can be an issue, as it's naturally low in folate.
Interesting. What else?
Then there are times when your body's demand for folate just shoots up.
Like pregnancy.
Pregnancy is the classic example, yeah.
Yeah.
But also during periods of rapid growth, like adolescence. Certain conditions like malignancy, some blood disorders, chronic inflammatory states, even kidney dialysis can increase requirements.
Right, so increased need.
Increased need or sometimes excessive loss, maybe through urine in certain kidney conditions. And then there are medications.
Ah, yes, the antifolate drugs.
Exactly. Drugs like trimethoprim, methotrexate. The mechanism isn't always perfectly clear, but they can interfere with folate metabolism or absorption.
Okay.
And finally, though they're rare, there are some genetic disorders that affect how the body transports or uses folate.
That covers a lot of ground. So boiling that down, who are the main people at risk? Who really needs to be mindful of this?
Well, the risk factors directly mirror those causes, really.
Uh.
So definitely people with a poor diet, consistently lacking those green, leafy veg, legumes, fortified foods.
Okay.
Alcoholism is a major one. Anyone with a known malabsorption disorder.
Makes sense.
Pregnancy, as we've stressed, significantly increases the need. And individuals taking those specific antifolate medications we mentioned, those are the key groups.
Got it. So let's dig into the pathophysiology a bit. What's actually going wrong at a cellular level when folate is low?
Right, so think back to DNA synthesis and cell division. Folate, specifically in its active form, tetrahydrofolate, is like a key coenzyme required for making the building blocks of DNA, the purines and pyrimidines.
Okay, the DNA component.
Exactly. So when you don't have enough folate, you can't make DNA properly. This hits rapidly dividing cells the hardest.
Like in the bone marrow.
Precisely. The bone marrow is churning out blood cells constantly. If DNA synthesis is impaired, the cell division process gets disrupted. The cells try to divide, but they can't complete it properly, leading to these large, abnormal precursors in the marrow.
And that leads to the megaloblastic anemia.
Yes, you get fewer red cells produced, and the ones that are released are large, fragile, and don't live as long. That's the megaloblastic anemia, the macrocytosis you see in the blood count.
And does it affect other cells too?
It can, yes, because DNA synthesis is fundamental everywhere. It could affect white blood cells, platelets, cells lining the gut. And it's also thought to be linked to the neurological changes sometimes seen, although the exact mechanism there is less clear compared to B12 deficiency.
Okay, that clarifies the how. Now, differential diagnosis. If someone presents with symptoms or maybe that high MCV on a blood test, what else needs to be on the radar besides folate deficiency?
This is absolutely critical, especially for exams and practice. The number one differential, the one you must rule out, is vitamin B12 deficiency.
Why is that so important?
Because both can cause megaloblastic anemia, but the treatment is different. And here's the key point. If you give folic acid supplements to someone who is actually B12 deficient without also giving B12, you might improve the anemia picture slightly.
Oh, so it looks like it's getting better.
Exactly. It can mask the hematological signs of B12 deficiency. But you're not treating the underlying B12 problem, which can lead to progressive and potentially irreversible neurological damage.
Wow. Okay, so B12 first and foremost.
Always check B12.
Yeah.
After that, other causes of anemia need consideration, like iron deficiency, though that usually causes small red cells, not large ones.
Right, microcytic, not macrocytic.
Correct. Then there are other rarer causes of megaloblastic changes. But you also need to think broader. What else causes macrocytosis, even without those typical megaloblastic features in the bone marrow or blood film?
Okay, what sort of things?
Things like pregnancy itself can raise the MCV slightly. Alcohol excess is a very common cause of macrocytosis. Liver disease, too. An increased number of young red blood cells called reticulocytes, that's reticulocytosis, can push up the average size. Also, hypothyroidism, certain bone marrow failure states like aplastic anemia or myelodysplasia, some drugs like cytotoxics, even things like cold agglutinins messing with the lab test.
So quite a list. Is there a way to remember those non-megaloblastic causes?
It's a bit broad, but maybe think about things affecting the factory, the bone marrow, or the product, the red cells themselves, or even things interfering with the measurement. So increased production, reticulocytosis, faulty production, marrow disorders, liver disease, thyroid, alcohol effect, or just artifact. But the key is, check B12, consider folate, then think wider if needed.
That's helpful. What about how common this is, epidemiology, particularly here in the UK?
Yeah, it's considered relatively common both globally and within the UK. Yeah. But as we discussed with the risk factors, prevalence is definitely higher in specific groups.
The ones we listed before.
Exactly. Pregnant women, older adults, perhaps due to diet or absorption issues, people with those malabsorption conditions, and individuals with consistently poor dietary habits or significant alcohol intake. So not evenly distributed, but certainly not rare.
Okay. So clinical presentation. What are the actual signs and symptoms we should look out for? What might someone experience?
It can be quite variable. Often the onset is gradual. The most common symptoms are usually related to the anemia itself.
Like fatigue.
Fatigue, absolutely. Feeling weak, getting breathless more easily, looking pale, pallor. Those are very common.
Okay. Anything more specific?
Yes, a sore tongue, specifically glossitis, where the tongue looks red, smooth, and sore, is quite characteristic, though not always present.
Right, the smooth, sore tongue.
Some people might get gastrointestinal symptoms too, like mild diarrhea or nausea, and sometimes subtle cognitive changes. Difficulty concentrating, irritability, maybe low mood or depression.
Cognitive effects too.
Yes, although significant neurological symptoms, like peripheral neuropathy or balance problems, are much more strongly associated with B12 deficiency. Folate deficiency can sometimes cause mild neuropathy, but it's less common and less severe, typically.
How quickly do these symptoms develop?
But remember those limited body stores. It means deficiency can develop relatively quickly, often within about 4 months if someone's diet is very poor in folate. Faster still if there's increased demand, like in pregnancy, on top of poor intake.
Right.
It's also worth remembering some people might be largely asymptomatic, picked up on routine blood tests. Or their main symptoms might relate to the underlying cause, like the symptoms of celiac disease.
Okay. You mentioned a mnemonic earlier for the symptoms.
Yes, for remembering the common features, you could use fatigue.
Okay, let's hear it.
F for fatigue, A for anemia symptoms like pallor and breathlessness, T for tongue, changes glossitis, I for irritability or cognitive fuzziness, G for gut disturbances, and U for generally feeling unwell.
Fatigue. That's actually quite neat. Covers the key points.
Helps to jog the memory.
Definitely. So if a clinician suspects folic acid deficiency based on these symptoms or risk factors, what investigations are typically done to confirm it?
Okay, the diagnostic pathway usually starts with a full blood count, the FBC, and critically, a blood film review.
Looking for.
Looking for that high MCV mean corpuscular volume indicating large red cells,
Yeah.
macrocytosis, and on the film, you'd look for the macrocytes themselves, maybe hypersegmented neutrophils too, which are characteristic of megaloblastic anemia.
Right. And then the vitamin levels.
Absolutely. Step 2 is measuring serum folate and, crucially, serum vitamin B12 levels concurrently. Serum folate below a certain level, usually around 7 mmol, has traditionally indicated deficiency.
But you mentioned issues with serum folate.
Yeah, it can fluctuate quite a bit depending on what someone's eaten recently.
Yeah.
So while it's often the first test, sometimes red cell folate levels are checked.
Red cell folate.
Yes. It reflects the body's folate stores over the lifespan of the red blood cells, so it gives a better idea of long-term status. It can be particularly useful if the serum folate is borderline or doesn't quite fit the clinical picture. A low erythrocyte folate level, say under 349 mol, strongly suggests reduced stores.
Okay, so FBC, film, B12, serum folate, maybe red cell folate, anything else?
Well, if the cause of the deficiency isn't obvious from the history, like poor diet or pregnancy, then investigations to find the underlying cause are essential, particularly looking for malabsorption, so maybe celiac screening, for example.
Makes sense. Address the root cause.
Exactly. And depending on the broader clinical picture and the differential diagnoses we discussed, other tests like liver function tests, LFTs, gamma-GT, often raised with alcohol, or thyroid function tests, TFTs, might be needed to rule out other causes of macrocytosis.
Right. So key tests, FBC, film, B12 always, folate levels, serum plus red cell, and then investigate the cause if needed.
That's the core process, yes.
Okay, fantastic. So let's say we've confirmed folic acid deficiency and we've ruled out B12 deficiency or are treating both if needed. What's the management strategy based on UK guidelines?
The cornerstone of treatment is, unsurprisingly, folic acid supplementation. This is usually given as oral tablets.
What kind of dose?
For correcting an established deficiency, the standard dose is typically 5 milligrams of folic acid taken once daily. This is usually continued for about 4 months to replenish stores.
4 months at 5 milligram daily. Okay.
Yeah. Although, if malabsorption is the underlying problem, a higher dose, maybe up to 15 milligrams daily, might be needed.
And after those 4 months?
Depending on the cause and whether it's been resolved, a lower maintenance dose might be continued long-term, maybe 5 milligrams once a day, or even just once or twice a week.
Yeah.
But crucially, alongside the supplements, you must address the underlying cause.
Right, like treating celiac disease if that's the issue.
Precisely. Or providing support for alcohol reduction. Dietary counseling is also really important for long-term prevention, advising on incorporating those folate-rich foods regularly.
Makes sense. What about prevention in specific groups?
Yes, prophylaxis is key. For all women planning a pregnancy, or who could become pregnant, taking 400 micrograms, note, the lower dose of folic acid daily is recommended, starting before conception and continuing for the first 12 weeks of pregnancy.
To prevent neural tube defects.
Exactly, that's the primary goal there. In certain higher risk situations, like if the woman has had a previous NTD-affected pregnancy, or has diabetes, or is taking anti-epileptic medication, a much higher dose of 5 milligrams daily is recommended during pregnancy.
Okay, higher dose for higher risk.
Correct. Also, people on long-term renal dialysis often need prophylactic folic acid, typically 5 milligrams daily or weekly, and it's used to prevent methotrexate toxicity, usually 5 milligrams once a week, taken on a different day to the methotrexate.
Right, the methotrexate protection.
And we should also mention food fortification. In the UK, like in many other countries, non-wholemeal wheat flour is mandatorily fortified with folic acid, specifically to help reduce the incidence of neural tube defects at a population level.
Ah, so it's added to bread and things.
To flour, yes. which
Yeah.
then goes into bread, pasta, etc. It's been shown to be effective elsewhere, but ongoing monitoring is needed.
And that critical warning again.
Absolutely worth repeating. Never treat megaloblastic anemia with folic acid alone until vitamin B12 deficiency has been excluded or is being treated concurrently. Giving folate can mask the B12 deficiency anemia while allowing neurological damage to progress.
Crystal clear. Okay, so if treatment is given correctly and the underlying cause managed, what's the general outlook? The prognosis.
Generally, it's excellent. Folic acid deficiency is very treatable. With appropriate supplementation and addressing the root cause, symptoms usually resolve completely and the blood count normalizes.
That's good news.
Yeah, the complications can be prevented or reversed in most cases, so prognosis is typically very good.
What are those complications if it isn't treated or treatment is delayed?
If left untreated, the deficiency can lead to several problems. Severe megaloblastic anemia itself can cause significant fatigue, heart problems due to the strain, and reduced exercise tolerance.
Okay.
In pregnancy, the major risk is neural tube defects in the developing baby, like spina bifida.
Which is why preconception folate is so important.
Critically important. There can also be neurological impairments, like the mild peripheral neuropathy we mentioned, though again less common than with B12, and potentially an increased susceptibility to infections due to effects on white blood cells. So timely intervention really matters.
Definitely sounds like something you want to catch and treat properly.
Absolutely.
Okay, so let's try and wrap up this deep dive. Folic acid, clearly essential, involved in DNA, blood cells, development.
Really fundamental B vitamin.
Deficiency can come from diet, absorption issues, increased needs, or medications.
Lots of potential causes.
Key signs include fatigue, pallor, maybe that sore tongue, but symptoms can be vague.
Yeah, and always think about it with macrocytic anemia.
Diagnosis involves blood tests, FBC, film, folate levels, and always B12.
Cannot stress the B12 check enough.
And treatment involves folic acid supplements, tackling the root cause, dietary advice, and specific prevention strategies, especially around pregnancy.
Spot on. Management is usually straightforward and effective.
It really feels like understanding these details gives you, the listener, a bit more power to be proactive about your health or recognize potential issues.
Yeah, for sure. Knowledge is power here.
So here's a final thought to mull over. How are you doing with those colorful plant foods? Broccoli, leafy greens, beans, are they regulars on your plate? And do any of those risk factors we talked about, pregnancy planning, certain meds, gut issues apply to you? It's just a prompt to think about how interconnected things like diet, vitamins, and overall function really are.
A very good point. And for anyone wanting to consolidate this or revise other medical topics, especially for exams like the MSRA, definitely check out pastthemsra.com.
And there are great free resources, too, over at freemsra.com.
That's right. Lots of useful material on both sites.
Perfect. Well, thanks for joining us for this deep dive into folic acid deficiency.
Pleasure.
We'll catch you on the next one.